Okay, don't get me crying right when I get here, Tom. That's never a good thing. Karen, I loved your story, and I'm going to just pick right up, sort of right running where you took us to. This is a bit nerve-wracking. This is like doing a dissertation defense. Some of the people that were here yesterday and are here in this room have taught me so much. You are my professors for healthcare. One of them is this man, Tom Eads, who me and my team at Intel have spent a great deal of time of studying home-based primary care and what he's doing with adult foster care. I described Tom. Tom's not met my wife yet, but I tell my wife that I actually have a hero. I've met I meet amazing people, but Tom's one of my heroes, that if I could be more like him and have the impact on the quality of life that veterans do, I would know that my life was complete. So hearing Robin Stone here yesterday, I spent a lot of time of my life with Leading Age, then called ASA, forming the Center for Aging Services Technologies all those years ago to focus on advocacy. What Bruce has taught me about Enough to be Dangerous and introduced me to people in France and Israel working on hospital at home. I see Robert Jaron out there, who's taught me an enormous amount about policy work, and we work very closely with Robert and team at Qualcomm, with our Intel team. And there's many of you here, so it's a little bit nerve-wracking. It's also nerve-wracking because I am jet-lagged like you would not believe. I'll just give a quick health update. I know many of you personally. Just had my 2-year kidney transplant. September 24th was my 2-year anniversary. Perfectly normal kidney function with my transplant. For those of you that don't know, I got one. And I just had my quarterly cancer scan, and I'm cancer-free. So that's the good news. The bad news, all these countries, and I've never even met my China team, now they all know that I have no excuse not to travel. So I now travel over the world, working on, and finally was just in Beijing and got to meet my China team for the first ever. And I'm going to talk a little bit about what's going on there. So literally 2.5 hours ago, I was sitting in the hotel, changing this entire talk around, and I may just throw all these slides away and talk. I don't know. This is not sitting in the pocket yet for me, so we'll sort of see where this goes. But I have a lot of ground that I sort of want to cover and talk about today. So I talked about this as towards personal health, going home and beyond. And I'm going to actually start out, oops, I just hit the wrong button. I'm going to start out by just talking about my failures in some sense. I mean, you know, Tom's words notwithstanding, I feel like I've spent 30 years trying to take healthcare home and have mostly failed at doing so. Because it hasn't scaled yet, and because the kinds of capabilities that I know are going to be magical, from care models to payment models to technologies, have not scaled and made themselves widely available to enough people yet. For me, and I'm going to talk a little bit about this in more detail, all the hats that I've worn in my life, I didn't start as early as Karen. I was 16 when I started as a family caregiver for our grandfather with Alzheimer's, or grandmother with Alzheimer's. To my, 3 years later when I was 19, being diagnosed with this rare form of kidney cancer and told every year for the then following 23 years that you would die within a year. And sitting in cancer clinics and dialysis clinics eventually with people who are in their mostly 70s and 80s, my life is really sort of focused on aging. And I often say to people, I've had the diseases of people that normally get these things in their 70s and 80s at the young old age of 19, so that you would have, hopefully, be able to survive them and have the tenacity and the ferocity to sort of go after and change the barriers that were sort of making the experience of the illness worse than it needed to be because of the system that we were sort of enmeshed in. And then certainly as an academic, doing work on studies of nursing homes, my first attempt to sort of do a startup on home health technology, particularly for chronic care and telehealth, was in 1994 when I worked for Paul Allen, the co-founder of Microsoft. We were ready technically, but we were not ready. I thought telehealth was going to happen then, right? And it should have, because we were delivering quality of life to people then. But the perversities of incentive systems and the processes and policies that were in place were keeping that from happening. To more recent of doing corporate R&D and now being, strangely enough, a business executive running a health and life sciences business globally for Intel, which is still sort of baffling to me. But I'm going to sort of ground myself back in that sort of first experience as a caregiver and pick up where the previous talk was going. So when my grandmother did get Alzheimer's, we knew things had been going wrong for years. The euphemism in our family was her blood pressure was acting up again, or she's not taking her blood pressure meds, which was actually true. I now understand that she actually had most likely vascular-based dementia and was having a series of strokes all that time, but we didn't have language for it. Certainly the doctors didn't have language for it, and we didn't have the understanding of the kinds of dementias that both, that technologies and understanding are starting to give us. I learned to drive when I was 16. My grandfather called in a panic, and my parents were out to a movie or something. These were pre-cell phone days, so there was no way of getting in touch with him. And he called and said, Eric, Grandma almost sort of burned the house down. And she made amazing fried chicken and amazing chocolate cake, which I'm glad I can't have access to that anymore because I would not be able to say no. Part of her rhythm, she would just get up at 3 in the morning and think it was time to do that and get confused and put some things in the oven and just leave it on and go back to bed, and she'd almost burn down the house. So he had gotten the fire out. He's like, I need somebody here. I couldn't find my parents, so I saw the spare keys, grabbed them, and learned to drive an hour and a half drive between Charlotte and Kannapolis, North Carolina, where they live. I realized that we'd been there so many times, I knew how to get there. I just sort of went, but I learned how to drive that night, and then went and helped him. And over the next weekend, I came and I had my Commodore VIC-20 or Commodore 64 or whatever computer it was. I was a computer geek, even though I was also a drama geek and an English major and all of that. And I tried to build this system where I called the phone company and tried to combine some assets of the phone company from Radio Shack and my Commodore 64 computer and some sensors. Because the first thing I did was try to padlock her oven so she wouldn't use it at night, but she'd come down and get confused and start taking pieces of furniture and whacking at the oven trying to get the door open, so that did not work. So I wanted to build something that would alert us that she had opened the oven, that would call back to my grandfather, and so the phone would wake him up to say, hey, go down and actually turn this off. And it failed. I mean, it kind of worked, but this was the Internet of Things. I mean, now we have a sort of technology for this, right? We call it the Internet of Things. I was trying to build intelligent sensor networks with remote connectivity that let us go do that. And it absolutely failed. So my first experiment in how to do independent living technologies for seniors actually failed. But that took, that was the hook. That was I got on the bait of that at that moment in time and have never let it go. All right? I was like, there's got to be ways that we can change care models and use technologies to help with the exact problems that our previous speaker just mentioned and that I was experiencing back then. So it's funny, this is actually, if you look at these pictures, I'm 16 then, and look at that great sweater. I'm 19 here, so I'm older here, but this is my first week of chemotherapy. Cisplatinum, for those of you that know the drug, lovely drug. We don't do that to people very often anymore. Almost killed me. My wife got me this puppy, this dog, Abby, who was key to my survival. My dog ultimately died of kidney cancer. That dog devastated me. I couldn't go to work for 2 weeks. That couch I also thought was attractive at the time as I look at it. And that chemotherapy was so horrible and so miserable and so almost killed me that I swore to myself after I finished it that I would never let them do that to me again. And I learned from another patient on how to sort of take control of your own health. And I told them, starting that point and forward, I said, I will do chemotherapy as you wish. And I did it 21 more times over the next 23 years. And I said, you will do low dose over long periods of time, at home as much as possible, and you will optimize it so that I have maximum time for snow and exercise. And they did not like that. And it changed the course. And in fact, over the years, there was literally no field back in paper records or even in electronic health records today to put patient goals. So when the days electronic health records started, I would actually show them how they could use the nickname field to put snow and exercise guy in the field or snow obsessed dude in the nickname field. So it would remind them when they develop my treatment plan based on whatever's happened now, you are to optimize not for longevity, which is what you do, not for actually making these cells on a petri dish go away and these appear, but for me to be able to ski and for me to be able to exercise as much as possible. And if it meant I was only going to live to 25, so be it. And boy, it was hard to actually get a care system to optimize based on patient-centered goals. And I learned that lesson as I started doing patient advocacy for cancer patients all those years ago, started teaching that. And the reason I was so adamant about this was the 3 times I almost died in this 23-year journey that ended 2 years ago was that first chemotherapy round, because it was just too much, and it was too much at once. The second was a hospital-borne infection while on chemo in a Texas hospital some years later, and that was literally the closest to death's door. And then the third was from an over-medication from a care team that wasn't keeping track of each other and ended up causing heart problems that we fixed later and took care of, right? It wasn't the cancer. It was the system that was, with great intentions, trying to actually treat the cancer. And these were the things that sort of grounded me and also planted the hook of, we have to figure out how to do healthcare at home. And boy, did I have fights. I mean, I had fights even just 8 years ago, right? Oh, we can only do home care for people age 65 and above. That's all we're set up for. I'm like, what the heck, right? The second to last round of chemotherapy I did, it was 1/10 of the cost for me actually to do it at home. You could do self-infusion. There were remote patient monitoring technologies that I learned to do. And the system from the hospital to the oncologist to the payers fought me every step of the way. And I said, you've got the studies now, thanks to IOM and others, that show that hospitals are dangerous places. I'm incredibly immune compromised, and you're insisting that I continue to make the pilgrimage to the medical mainframe to do this. What the hell, right? So those two seeds, independent living technologies for seniors, giving them choice at home for as long as possible, and patient-centered goals that are focused on doing as much of this at home as possible, that's stuck, as they say. So given that I just came back from China, I want us to ask for a moment what we can learn from extremes. And I've been spending a lot of time. Each year I sort of set out a goal for myself of what I'm going to try to learn a lot about that year. And this is the year of Asia for me, since I'm spending a lot of time there and need to try to at least pretend I know what I'm doing. And last year it was genomics. And so every year, it's like, because it's all these things we get into, and it's like, holy crap, I have to speak about this, so I better learn something about it. So I want to sort of think about learning from extremes. Now, we all know demographics. I'm going to talk about global aging a little bit more later. But if you look to Asia, right, the sort of, as they say in Japan, we moved from a kite to a tree, where you can see the age curves in the various Asian countries, and Japan being the sort of harbinger of what's to come in the rest of the world with the aging society. You see them in the 1950s, and you see them in 2050 with a whole lot of people at the top of that tree who are much older. We all know this. So, invention is often driven more by necessity than opportunity, and they're having to sort of reinvent themselves faster than arguably we in the United States are because of lack of resources and that demographic challenge. If you think back, I live in Oregon, we get these reports about what kind of stuff is still coming over from the Japan tsunami, some of this debris. If you think back to the earthquake and the tsunami, the first images that were so arresting for me were these, and I'm sure you all saw them as well, right? And it was just the sort of sheer devastation of what the tsunami did and what the earthquake did, and then, of course, all of the fears around Fukushima and what was going on there. But as you actually looked at the footage and paid attention to it, it was really interesting. The people recovering all had a lot of gray hair. I mean, if you just go back and look at the news footage, it was just arresting, really, right? It was like you don't see that many old people on American television unless you're watching reruns of Golden Girls, right? We don't put old people on television because we're such a youth-centered society, right? It was like, oh my gosh, right? These are the people that are out in their 70s and 80s trying to recover and do all this physical labor. And it was just sort of a real wake-up call to me as I would watch this footage and have this sort of secondary reaction. And one of the things that they learned, and Intel's doing work with them as they rebuild in the Miyagi prefecture and in that area, was that like in the Katrina situation, having their medical records, their medical capacity, their medical expertise all centralized in one place, when that place gets devastated, you are incapacitated from delivering high quality or in any care at the most extreme moments of need. And if you actually look back at what they're doing now as they rebuild, they are very much headed towards a care model that is home and community-based as the primary approach, that is not centralizing its care capacity, its care technologies, and its care records. And it took the extremity of a wave coming in and like sort of wiping them clean and having a clean sheet of paper to sort of both realize the need and the opportunity to rethink things differently. Similarly, so if we think about China, I often put this slide up for people who aren't really, don't really understand the scale of China. So it shows it about the size of the United States, and it sort of maps things on here and gives you things like, the Hunan province has 63 million people, France has 60 million, right? Every year for the Chinese New Year, the most important holiday, 350 million domestic travelers, right? That's the population of Europe, right? I mean, just the scale of what's happening in China is just enormous. And the creation of urban environments. So here's their, sort of demographic growth challenges as they go to 2050. By 2020, China will spend actually more than the United States on healthcare. It could be 2025, depends on whose report you read. So they're moving up, and they're second very soon, and then there's places where they sort of overtake us. Now we know they're spending far less per capita than we are, right? But just the sheer cost of dealing with that aging population in China is an enormous thing. So they have extreme need, right? And one of the consequences is the one-child policy, right? They now have an average couple trying to take care of 4, sometimes 8, if the great-grandparents are alive, older people. Mass urbanization means a lot of them have been displaced from their parents or they've gone overseas. The Chinese government recently actually passed legislation or passed a law that said, thou shalt take care of your aging parents, right? Because it's become such a cultural problem for them. And they know its extreme demographic need and this extreme economic challenge is driving some really innovative things. So we started working with them. We've been trying to think about age-friendly cities for about a decade now, and just the design of cities and the design, certainly from an Intel perspective, the technology infrastructure to enable that. So what can we sort of learn from what's going on there? And it's interesting combinations of ministries there. The Ministry of China Association of Social Welfare, the Minister of Health, which last month changed its name, and I can't remember the new name of it. So it's bringing together, and this is one of the policy challenges we see everywhere. I think it just got mentioned in the summary from yesterday. The constituencies and the funding pools that are on the medical side, the social care side, how do you bring in private family dollars and create the kind of care flexibility where a team can actually decide what that particular individual or that particular family needs, as opposed to sort of the strings attached that say, well, now you can use this for meals, you can use this for technology, you can use this for medical care, which we all know it doesn't work. So where they're headed, now, it was interesting. I met the then Minister of China, the Minister of Health from China at HIMSS. It must have been about a decade ago. This wizened gentleman sort of comes up to me at HIMSS and says, I couldn't quite understand what he was saying. He's like, we want to shift left and shift left. And I was like, what is he talking about? And I'm going to talk about the shift left strategy in a minute. It was a strategy that I'd written on a napkin for Andy Grove, and I was trying to get us to get started on home health and independent living and Intel, and I'll talk about it in a minute. And it took years of conversation before we ever started talking about any technology. And some of the first things that we actually did with just trying to support the Chinese government, with many other players who were trying to help them, it's not like we did this work alone, was to just start with a basic capacity analysis. How many doctors and nurses do you actually have? How many are actually trained in geriatric care? The official numbers and what they gave us were very different, right? And then what's the need, right, in terms of what you've got coming? And you very quickly, I'm a qualitative social scientist. I don't have great statistical skills, but even I could do the math that sort of says, oh, okay, this is not a physician and nurse-driven model. Most of these people will never even come close to a physician or nurse in their lifetime. It's going to have to be a community health worker-driven model. You're going to have to use capabilities to sort of enlist family members and neighbors in some pretty intensive ways if you're to have any chance of trying to deal with the demographic wave that you've actually got coming. And then the whole second discussion was about how do you finance long-term care? I mean, they don't have Social Security. They didn't have sort of a model for this. So we brought in experts from around the world. And then we brought in experts from around the world to just teach them different community-based care models. It sounds like you guys had some good discussions of some yesterday. I want to make sure I actually see that, right? Forget technology, forget payment, for anything else. Just like, who knows how to do this well? This is why we went and started studying Tom's home-based primary care program. I was like, hey, the future of care is team-based, collaborative, in the community, and holistic. Who does that well so we can just learn from it now, and then let's try to think about what would it take to scale those, right? That's why we actually did this. So where they're headed now is a strategy focused on developing a community care workforce, infrastructure, and business model, ultimately for all ages. So it's a sort of universal design argument. Aim for the extremes of this age wave that's coming, but the infrastructure that they're going to put in place is not just for elder care, it's going to be for people of all ages as they go forward. And what they're really trying to build out is a care flow services network in terms of business models and infrastructure that allows lots of different companies and lots of different agencies to use a common infrastructure to be able to deliver care in the community, right? So whether it's government providers of services, other benefit providers, medical service providers, care providers, children and relatives, having a common infrastructure and framework that allows for lots of innovation of applications and services on top of it so that it can actually do this community-based care model. And how do they actually achieve economic scale with this beyond just the sort of initial pilots that get done and then nobody actually ever scales it, right? I mean, today, I didn't bring one with me. Well, let's see if it's in my wallet. I don't think it is. The benefit design is these coupon books for a lot of people they're handed out, and here's your coupon for meals, and there's tons of fraud. There's no real understanding of the utilization of services. It is not a terribly sort of innovative model, right? And the Chinese government cannot continue to write more checks for coupons as that demographic age wave happens. Something else has to change in this particular paradigm. So really that sort of economic scalability is key. So what have we been working with them on, right? These are new platforms built on everyday life technologies, i.e. the infrastructure they're going to put in place already for smart railway systems, for smart communications, for smart shopping, the smartphones, the tablets, the stuff that's already around, and really trying to converge multiple things here, right? Platforms for daily living services, right? House, laundry, food, all of that. Health management and medical services. So when they think about this, they don't just come in and think about healthcare, which is what we do way too often in the US. We just sort of think about the healthcare stuff and everything else is taken care of. The social engagement platform, and then what are security services for safe and secure living. And by the way, these themes have emerged in our ethnographic work of the 92 countries now where we have studied the aging experience, from the family caregivers to the professionals to the seniors themselves. So this is what they're trying to build out and test. Now, it was really funny. When we first started working with them, they're like, we're going to do this at a street level. I'm like, why the heck are you going to do this at a street level? And they're like, we're going to develop this sort of business entity and the infrastructure at a street level. And so for almost a year and a half, we're going along and working with them and on these committees and sort of going through all this. And we're like, wow, we think this is a really bad idea, but it's their culture, they're local, they understand what's going on. And then finally one day, we're like, okay, how many older people do you have on this particular street? It's like 893,000. It's like, oh. Street level, okay. That makes a whole lot of sense. So in the urban areas, right, they literally are going to build this services infrastructure at a street level, build a branded sense of identity of all the people that live on this street, and you can have 1 million seniors living on a particular street, right? In the village areas, obviously, you would build out one infrastructure for all of that. So that's part of the challenge as you're sort of doing this design, is thinking about scaling from small rural settings to medium-sized towns to the megacities that they're actually building from scratch. And part of what they're going to go do is build 20 new megacities from scratch with this age-friendly city infrastructure in place, but also looking at how do they retrofit existing cities to be able to carry this work forward. So they have a plan, right? China's trying to lead to build out this infrastructure for themselves, for these kinds of personal health technologies and industries and new workforce. By 2020, they're trying to drive 90% of care for older people to the home, and their current 5-year national plan was to drive these age-friendly cities initiatives and get started with them, right? I mean, and there's places to stand across agencies there to actually go make this happen. So I sort of share with these right away just because they're fresh in my mind, and I think the extremity of need sort of shows sort of how to do the innovation. And in both the case of Japan, where a wave wipes the clean slate, and in China, where you're not looking at an installed infrastructure of the old way of doing things that you need to defend, you get the ability to do the design thinking process that says, don't think about the way that it's been done. Think first about the care model, second about what the business model should be, and then third and finally what the technology needs to be. And I'm going to echo that theme a number of times here. All right, this is where I'm totally confused because I've moved all these sections around and all this. So I'm going to go to a different place now. I'm going to talk a little bit about the strategic framework. You could call this what's old is new again. Some of you have seen me present some of these same slides for literally 15 years now. And I had a bunch of new stuff I was going to share with you on genomics and consumer health technologies, and I decided, you know what? It's not what's important. It's like, yes, the technologies are actually improving. And I'm not going to give you a technology talk today. If you want in the Q&A, we can talk about what we see happening in the world of mobile health and tablets. And yes, my team works on next generation phones and what are the capabilities that we can all count on them having, all the way to how do we make genomics data sort of a viable data set for everybody on the planet, right? I mean, yes, those are important things, but what's most important is the care model innovation and the business model innovation and the business process and innovation techniques to get us from here to there in places where we do have an entrenched history that defends itself in some industries that don't want to go away or don't want to transform. So for a long time, I've been calling this shifting from mainframe to personal health, right? We all know the numbers. I think about global aging as the other inconvenient truth. Why it hasn't sort of grabbed on like global warming has, I guess maybe there will be global aging deniers too, but that one's going to be a much more difficult to actually think. It's like, yeah, no, you're aging. See, it just happened. You just aged. So, this is 2002. You already see Western Europe in 20 to 30% of their population over the age of and 60 for these particular numbers. This is what it looks like in 2050. There's lots of ways to sort of cut the data. what I basically called is the double-double between 2000 and 2050. We get a double-double. 600 million people over the age of 65 to 1.2 billion by 2025 to over 2 billion by 2050. Right? The other way to really think about this, and this is the way I really think about it, is the crossover point, what a lot of demographers call the crossover point. I remember when I first testified before Congress about this. It was like 12 years ago, and it's like my learning how to put on a tie in the Capitol as I go in and actually do. Literally, I had a senator actually helping me tie my tie because I wasn't very good at it. And I walked in and I talked about the crossover point. I said, the good news is we got until 2017. At that point, I think the numbers said it was going to be 2020, but it's been pulled into 2017. When we'll have more people over age of 65 on the planet than under 5 for the first time in human history, right? I mean, you can see the math here, right? It's 2017 now is when this crossover point occurs. We do not know as a global society how to deal with this yet. And we're just sort of like nibbling around the edges of figuring out what does sustainable healthcare and economics look like in a world of global aging, right? And I would say there do need to be sort of the moral equivalent of green technologies for global warming, of gray technologies for global aging that will benefit not just old people, but people in general as we deal with the fact that we're going to live in a world that is predominantly older going forward. So as a result, or not just entirely as a result, healthcare costs are rising around the world. Every country that we go to, at a central national level down to the local provinces, or down to the local towns, are dealing with the triple aim. They don't call it the triple aim, and they don't know who Don Berwick is, right? But it's like, how do we drive cost, quality, and access in this world where we've got more people to care for who are going to be more increasingly expensive? And how the heck do we keep the cohorts that are coming from behind them from developing and having the same chronic conditions that are going to lead to this long, expensive, and hopefully increasing quality of life, right? I mean, it's like, Spock from Star Trek. You want to live long and prosper. We've gotten very good at live long, but we need to make sure that prosper is working out, or it will really stink to live to be 150 if you're miserable. So healthcare costs are rising, health worker shortages, huge immigration issues around the world that we talk about. It was true in China. It's true in Singapore. It's true in the European Union, where I was visiting a couple of months ago. Huge immigration challenges because countries are often bringing in immigrants to do their sort of care. It's like, no one else wants these jobs, right? So, I mean, there's just enormous, we just don't have enough people in the workforce to actually go do this. So we have to create new kinds of workforce and sort of deal with these strategies. So the piece of paper that I wrote this on years ago, I just said, we got to shift left. And we've added to this over a period of time. But conceptually, this is the diagram. But do it on a napkin. Still have the napkins. Pretty faded. Quality of life on the vertical axis, cost of care. And, none of us want to be in the intensive care unit. It's a low quality of life, and it's very expensive per day, right? And I ultimately added another line here that said, and it requires an enormous amount of expertise to actually be cared for in that setting, right? And the timing from a sort of intervention perspective is really late, right? By the time you're in the intensive care, it's like, this is a very reactive, and that's the challenge, right? So I used to say to Intel, it's like, look, we ought to be investing in innovations, whether they're policy innovations or technology innovations that help us stay left or shift left, right? And can we take things that were only available in an ICU, like technology-wise, and make them available in primary care or even in the home? Think about the migration of ultrasound. Some of you have seen the TED Talk that I gave recently, right? I mean, ultrasound was this big iron equipment that used to only sit in this sort of big, expensive medical mainframes. And now, I mean, people aren't happy with me, but I actually used it on stage to take control of the device myself and show my new kidney, right? It's not designed for that yet. Full FDA sort of warning. It's not approved by patients to be able to use on themselves. But if you think the day is not coming where the agents and algorithms on the automatic ultrasound that connects to your cell phone are not going to be a piece of consumer electronics, you got another thing coming. I give it maybe 5 years in the US and like yesterday in parts of Asia, right? So that migration of technologies that are shifting left is already happening, right? As all of those capabilities. I mean, just think about the smartphones and the capabilities that are now launching. And we're trying to catch up with the world and try to figure out, what does this mean for healthcare? What does this mean from a safety and security perspective? What does this mean from a regulatory perspective, right? These are hard issues. But also shift left from a sort of place shifting and skill shifting. How do we shift care, right, to the less expensive, higher quality of life domains? How do we skill shift so that, there are people way here on the left that can start to do some of the things that were only the purview of the right, because we don't have enough capacity of the stuff on the right for everybody that's going to need access to it. And how do we time shift, meaning don't do reactive medicine, do preventive care, do fundamental primary care, and keep those right-hand things from ever happening. So this is conceptually the framework that we use. And literally when my team proposes everything from research to product work that we're going to do with partners or policy work, I sort of layer it against this. And is it going to help us shift left or stay left in terms of the principles that we're trying to guide our investments around? So there's two aspects of this, right? Distributing from that mainframe campus model. So it's not that we're going to get rid of hospitals completely or other large institutions like nursing homes. You're going to have smaller ones, and you take that capacity and embed it into the rest of the community, right? So need smaller mainframes, medical mainframes, distribute that capacity to the home, the workplace, and so forth. Intel is a large employer, has had a very consumer-directed approach. We're in our sort of third generation. The first phase was just to get people to start to sign up for consumer-directed health plans and start to think about a very different relationship with your health plan. The second phase was, health for life centers on campus, the ability to get primary care on campus, to be able to start to sign up for other kinds of coaching and risk stratification for yourself. And now we're going to different places where we're going to make our providers start to deliver home-based care as a default model, use telehealth, use mobile health, and track quality goals that are based on the individuals as well as the collective of the patients that we have and pay based on that, right? So we're on this progression as a large employer, learning as we go. We don't have it all right, but sort of struggling to figure out this distributed capacity. And the workplace itself is one of the key nodes of care now, right? And it's going to become a larger node of care for us as we go forward. So this is the problem that we've got. I've shown this slide for a long, long time. In 1784, the first general hospital was basically invented in Vienna. In 1850 was the second general hospital that really started the whole focus on curriculum and how do you sort of design fields of experts to actually fit into this hospital, right? And it was a really important invention almost 300 years ago, right, to actually come up with the notion that have problem, make a pilgrimage to a place where the experts can be with experts technology, and you timeshare that system, just like we used to timeshare the early computers that took up rooms this size and were mainframe computers, right? We couldn't conceptualize back then that the power of personal computing was going to become truly personal. You get to use it. You don't need a systems operator. You don't make the travel to an expert place. It's yours, and you can actually do with it what you want. Healthcare needs to move in a similar way from this mainframe-centric model to a personal health model, right? There's the metaphor. I think I would probably use that metaphor even if I didn't work at Intel, but it's helpful when you actually use that metaphor at Intel, right? So I'm not anti-hospital, but I'm like, stop using the wrong tool for the job for the vast majority of care, right? So here's a medical mainframe. This is Providence St. Vincent in Oregon. They have helped to save my life. There are times I need to be at a hospital. Though they can tell you that they fought with me a lot on having chemotherapy at home or doing drive-bys. I remember one Thanksgiving, I was on, oh God, we used to call them shark shakes. I've forgotten the drug. It's an anti-angiogenesis that they thought was going to be really helpful for cancer. I can't remember it anymore, but he had to drink this thing. And I was like, I refuse to come in and actually do this in the hospital. And it was Thanksgiving Day. And I came, and I had conned the nurses into letting me not do it in the hospital. I drove up outside. They ran out, and they had decorated the thing that I have to drink with the tail and head feathers of a turkey. It did not taste like turkey, let me tell you. Right? I mean, so this place was really important to me, but even when I needed to go there, I was pushing against them constantly saying, why can't you do this at home? Why can't you do this at home? What's the safety barrier? Let's figure out how to overcome that one, right? Now, we're so focused on the hospital, and when Intel does these studies of people around the world, we have them do these things called place maps. So our social scientists go out and live with and observe people in real-world settings, right? So often, people will show us the main hospital where their child was born or their life was saved from the heart attack, and they have a very positive relationship with that hospital in most cases. When they don't, we get about an hour of tape that we can't use because it's just like curse, curse, curse. But most of the time, they actually love their hospital and have a very positive association with it. But the problem is when we ask people to map out all the other places that are key nodes of care, they list all these other places. No, we literally Google map their lives, and they sort of map all these places. I didn't put it in here, but I have my map of all the places that I have to manage for care across states and countries and clinics and hospitals and specialists and so forth. It's a very complex map. Big data analytics needed for that one. So they map out all their nodes of care, And then the people that are key to their care, right? Their therapist, their gerontologist, a librarian who's helped them look up information because they're not good at looking up trusted information on the internet, right? Whatever it is, it's a different configuration for different people. But that's the lived reality of health for people. And if we don't develop an information system and a reward system and a care model system that takes in that sort of community-based care, and the home being a key node in that, and probably the workplace as well, then we're not going to create a sustainable healthcare system going forward. The other aspect of this, so step one of mainframe to personal health is distributing the capacity, right? And skill shifting, place shifting, and time shifting. You know, the second piece of this is when we invented those hospitals back in 1784, and then the whole notion of med schools to actually support it and specialty-driven care, right? We started breaking up the human body into individual little pieces, but nobody's put Humpty Dumpty back together again. So, I mean, these are just some of the specialties that you can actually go into. I'm going to have a swig of water if anybody's got it while this actually finishes. Oh, I don't have any water left. So it's not that this is bad. We needed specialty care. We needed to actually understand what was going on with different organs and systems and cells. And my God, genomics and the modeling of an individual cell is something that we're actually working on now, right? But the problem is the reintegration, right? Thank you. We've so sort of put people into the frame of reference of the parts of their body. I remember I would walk into tier 1 academic universities as a young guy with these rare cancers, and I could just see publish or perish written all over me, right? And whatever drugs their university was known for became a bias in what they actually wanted to put me on. Again, not bad people, well-intentioned, but biased in ways that they can't even imagine because their point of view is focused by the drugs they study, the things they understand, the things that are making their career successful. If you don't understand as patients that there are humans on the other end with different motives and sort of backgrounds to this, you're going to be in trouble. This is why you get second, third, fourth, fifth opinions, right? Because you don't know what blinders any individual who's making these life and death decisions on you has. So this is a big challenge, right? And we don't have an information or an informatics or an analytics system that can really deal with this. This is a picture of a population view. So yes, we're starting to do big data analytics on claims data to start to do risk stratification in a more robust way and all of that. But I'm not a population. You know, the reason they thought I was going to die within a year was because they were comparing me to the limited data of 70s and 80-year-olds who had the particular form of renal cell carcinoma, which I actually didn't have, I now understand, and sort of surmising from that you're going to die in a year, right? It was almost, you know, immoral to sort of give me those proclamations. They should have said, we don't actually really have data on young people like you because young people like you don't get these kinds of cancers, right? So the population view, while telling us some things, doesn't tell us much about the individual. At the same token, you know, understanding everything about just your cells, but not popping back up a level and looking at what is your family situation, what are your goals, also doesn't capture everything. So we need those data types. And we're moving to a world in which we're starting to collect all of these different kind of data types to be able to develop a model of you, right? And consumer-generated data coming from smartphones and all of that is now something that's going to have to be reckoned with by the system. And I can tell you the small places where we've worked with it in the world, where they've started to use it. We have this huge project with Parkinson's, the Michael J. Fox Foundation that we've just launched, where we're just trying to capture all this consumer-generated data around Parkinson's and motion and put it all in one place and run machine learning algorithms on it so that we can create hypotheses that are informed by big data analytics about where might be the interesting places to dig down to look for how to stop or how to monitor disease progression more carefully, or how to perhaps differentiate different kinds of Parkinson's so that you can figure out that piece is really treatable and that part is not, right? Or how do you titrate somebody's medications based on what's going on with them today, not the last time that they actually came into the clinic, and we got a, you know, false reading based on their trying to perform well on their Parkinson's test in front of their neurologist, right? I mean, that kind of world is coming, and we've got to have an informatics that can personalize down to that level. All right. I'm going to share this with you because it, in some ways, starts to capture. I mean, and this is one of the challenges I'm going to make to this audience. One of the big challenges when you're so mired in mainframe thinking is to just get a sense of what it might feel like. If home-based and community-based care was the default for all of us, you know, what would it start to feel like? And I don't think that this video captures all of it, but we did this 15 years ago to try to plant the seed. And one of the things that this group of people might want to think about is, how do we take all the sort of advances that are happening in healthcare today and sort of where we're going on an economic curve and a demographic curve and start to get all the stakeholders to understand what their life might be like, whether it's the nurses, whether it's the physicians, whether it's the family caregivers, whether it's patients or people themselves. So I'll share this with you. Some of you have seen it. It's got some old references to Vioxx that will crack you up. All right. Oh, we need more volume. Crank it up. I'll try it again.
Since my father-in-law died, my mother-in-law lives and hour depending on traffic.
Huh. All right, I might not play it. Can you guys hear her speaking?
We use it a lot, but we can't be there all the time, you know.
Okay, you're going to have to interpret. I can't get the volume any louder. I'll stop. I don't know why it's actually doing it. Okay, so this was starting to sort of show the basic paradigm of saying, what if you enlisted the family with the use of some technologies that were in the background to fundamentally make them part of the care team? One of the things that we're actually exploring in China is we're putting training in place, and we're having to invent new kinds of care workers that I don't have translations for because they don't exist in the United States and because I don't speak Mandarin, right? But what's the curriculum, the training, and just like you're going to start to track the quality of care that's being provided from a primary caregiver or a surgeon, you're going to track the quality of care being done by neighbors and by family members, right? And put incentives in place to actually go do that. So we tried to capture sort of a vision of what that might look like, as well as back then, this was a radical idea. We were showing simple sensors in the home, starting to capture things, starting to look at trend lines, starting to get sort of anticipatory analytics, trying to fend off falls before they happen, trying to help with some of the behavior challenges around meds compliance, and trying to give people social support, which for older people it's been one of the themes of our, maybe it's because I'm a communication scholar by training, but it's been one of the themes of our work since we started it 15 years ago was, if the social network goes, so goes everything else, right? And if you can't maintain the social network, then you're going to have to rely on institutional systems. Cost goes up, quality of life goes down, and it's just sort of this vicious circle after that. All right, good to know I can't play videos, or at least that one. We'll try another one in a little bit. So let me just talk a little bit about the pillars of personal health and the sort of paradigm as we think about it now. And I'm not going to go into this in a lot of detail, but we can talk about it in some of the discussion. I try to simplify it as sort of three fundamental pillars: care networking, care anywhere, and care customization. And care networking here, I really mean just it's the shift from institutions. Oops, sorry, I got these backwards. It should say care anywhere on the left and care network on the right. I'll start with care anywhere. It's really the shift from institutions to mobile, home-based, and community-based care, right? So when I think about the phrase home care, it has so many associations with it that it's not quite, and I think you talked about this some yesterday, it's not quite the right language to sort of capture what we're talking about. I don't mean to demean existing home care agencies and home care services in any way, shape, or form. I heard the overview of Robin's comments yesterday. The variety of home-based services that's all sort of encapsulated under home care, and the culture, especially in the US and Europe, still have such antiquated notions of both home care and nursing homes that they don't actually understand the range of options that are available now that they can actually get that are much higher quality than their old notions, right? The branding of what's coming hasn't come forward. So we've been really talking about this as care anywhere. Sometimes we and I focus specifically on the home in an extreme way because we're trying to do that as an antidote to the very hospital, clinic, nursing home-centric model, right? But you don't want to sort of overstate the home. It's really about community-based care, and making the home a fundamental node in that connected community system is key. So that kind of care networking and the technology infrastructure, the business models, the care models that actually facilitate it is key. In terms of care networking, this is about the shift from solo to team-based practice, right? And the IT systems to actually connect all these people and devices. If you look at clinical decision support tools that are coming out today, they're mostly for an individual. They're not really clinical decision support tools designed for a care team that actually includes trained family members and neighbors as part of that. Think about a world in which you're having data updates and everybody else in the network can sort of know what's going on. How does the care plan change with the patient's goals given new data that's come in, or given that what one person in the network has seen or noticed how does that group-based sort of groupware for clinical decision support or care decision support is going to be a key capability going forward. And then the final bit is care customization. So the shift from population-based to person-based treatment. And certainly that's genomics, but that's also using people's smartphones with intelligent algorithms that help them know, given their behavior and past behavior with the medication reminding system, how to take their meds on time, right? We did early studies, I won't bring up the prototypes here, but we did early studies a decade ago of meds prompting and reminding, and just did some simple things with simple sensors that were hard to do back then that let people have the voice of Oprah remind them to take their meds, or be reminded on their phone. And the point was, you could ultimately end up developing a really good, consistent behavior change for an individual if you had adaptive technologies that could actually be adjusted in their way. Some people want to be reminded on the television. Some people were like, if you interrupt the NFL, I will kill you and turn the whole system off, right? And this was hard to do 10 to 15 years ago. It is easy to do now, right? The ability to do customized care and behavior change on individual devices is there. The hard parts are going to be the methodologies to figure out what works and doesn't work, because it's mass customization, right? You're not going to be able to control for the experience in the same way going forward to really understand what are the value levers and the dials that exist across people and within people to actually get them to change their behavior. So care customization certainly involves things like genomics, but as well as those others. So I'm not going to read through all this, but if you sort of unpack care networking, a lot of this is about skill shifting to patients and family. I'm going to give you guys these slides, by the way. We'll put them on whatever website you want. Skill shifting to patients and family. So part of care networking is the efforts to make families formally part of that care system, or neighbors or whatever, right? Shifting to self-service. So if we're not sort of looking massively at self-care, people will say to me, oh, I've got frail seniors who will never be able to do this. We have taught frail seniors in many cases who are perfectly able to do these things if the technologies are usable, if the value proposition to them is clear. And what I say to people is like, let's assume that only 20% of patients can take on self-care. 20% of patients taking on self-care would be a great thing, right? That's going to move the needle on cost, quality, and access. So it's like, we've got to stop getting this mentality. 100% of people can't do this. It's like, that doesn't mean we shouldn't focus on the 20 to 30% who can as early adopters, and over a decade, more people will actually get good at it. We forget diffusion of innovation curves. So we've got to focus on self-care, systems, technologies, and training as a fundamental piece of that. The shift from transaction-based care to care coordination and software tools that really facilitate care coordination. I talked about shifting clinical decision support to groups. And then the shift from quality analytics that are sort of based on batch reports to things that are coming in real time and how that adjusted based on the model, right? There's a bunch of challenges within this care networking. Now, we know that if you don't have a basic electronic health record system that gets demedicalized and more lifeized to include data types that are more broad than just traditional medicine, we're going to be in trouble. And I don't know if different data systems are going to emerge, and we're going to have the medical stuff's going to come through the EHR, the consumer-generated data stuff's going to come through the PHR, the diagnostic stuff's going to come through the diagnostic HR or whatever, right? But the point is, it's like we've got to broaden the sort of definition of the data types that are coming in and figure out how to make these things standards-based, interoperable, and so forth. And that's a lot of work that Intel actually does. In terms of care anywhere, it is about using telehealth. It is about remote patient monitoring that are increasingly not going to be specific devices, but are going to be embedded into the everyday devices that we have, like it or not. Now, there's huge issues there about how do you know that the device actually wasn't tampered with, or it's adjusted and it's actually sending the correct data. There's all these sort of challenges that some of them are technical and some of them are policy, but that world is coming. So we have to get out of this mindset that everything that we need to do needs to be expensive, purpose-built, starting from scratch. It's going to leverage the stuff that's on the diffusion of innovation path. It's going to get cheaper, cheaper, and cheaper so that it's more widely available from an access perspective. Yes, it's often, though it's interesting, not always true, it's often true that the diffusion of innovation curve starts with those with the most money and then eventually gets the others. It's not always true. When Intel started out to try to go study the first smartphones in existence that we could find in the United States, it was with the homeless community. Because they could afford, even though it was very expensive at the time, to actually get a smartphone that gave them a residence. If you're trying to get out of homelessness and back into the world and you don't have a place that's a consistent place that can be called, right, then you can't sign up for social services, you can't do anything else, right? So the very first place, it was not businessmen sort of in America, it was actually homeless people, right? So it's not always true that diffusion of innovation curve starts with the wealthy and sort of trickles down, if you will. The shift to self-care and training and coaching agents, the shift to DIY consumerized medical device, the example of the, think about the AED, the defibrillator, right? I mean, who would have thought a decade ago that this was going to be a piece of consumer electronics that, many men in America had as one of the top 5 things that they actually wanted for Christmas 5 years ago, right? I mean, it's just sort of crazy, right? But that trend of medical device, of the consumerization of medical devices and the medicalization of consumer devices is going to be part of this care anywhere trend that's coming. And then part of this is enabling clinicians to be on the go. We are going to have to train and give capability to people, to clinicians, so that they can do mixed mode care. Sometimes I'm in clinic, sometimes I'm in hospital, sometimes I'm in home, sometimes I'm in community health center. And the tablets that they're carrying and the infrastructure that's in place needs to give them access. And we've been working with Tom's team. They get really frustrated when they're out and they don't have internet connectivity in the phone and they can't get the VA data back, right? I mean, there's still some challenges that the technology industry needs to do to really facilitate highly mobile workflows from a clinical workforce as we go forward. And then finally, care customization, right? Some of this sounds really science fiction-y, right? Customized to my behavior, my biology, my body. The shift to genomics, the shift to proteomics is happening pretty darn quickly, at least in cancer and rare inherited disorders. Intel's doing a lot to try to make the computing of that come down so it's incredibly available and gets cheaper and cheaper all the time. The shift to the incorporation of patient goals in care plans. This is actually a pretty difficult machine learning problem. Taking all the data that we've got and then putting some patient goals, trying to translate those goals into semantics that a system can understand and that then the rest of the data information can be adjusted for is not an easy problem. I mean, we could start out just by, let's create a field in electronic health records called patient goals, just so that we have the right conversations in clinical settings. But the analytics where a system can adapt to the patient goals and suggest different things is a pretty darn difficult informatics and computing problem. The shift to predictive modeling, the shift to precision therapy. So in my own case, it was a whole genome sequence that saved my life, that and an Intel employee who donated a kidney to me. When I walked into it was just 3.75 years ago, full kidney failure, not on dialysis yet, very ill, didn't see a lot of you for a very long time because I couldn't travel anymore. I think there were people at Intel and elsewhere that's like, oh my God, I thought you died. I mean, like I've come back reborn, and they're like, oh. I was like, no, I did not die. But it was getting very bleak, and a company that had seen me speak about a decade earlier at a nephrology conference remembered that I had had kidney cancer, and they said, well, I know you're not a biologist, you're having trouble understanding our genomic technology. Why don't we sequence you? It's like, okay, what the heck? And they did it, and we sent some tissue from my last tumor biopsy and sent blood to them and all of this. And in that particular case, they got lucky, and they spent 6 months doing analysis and then came back and said, 95%, 92% of what we ever put you on we now understand was destined not to work. So all those drugs, all those times. But I mean, my wife's still resentful of this. And I'm like, come on, there was no way of knowing. It's like, being mad that you didn't have a flying car in the horse and buggy era. Why don't we have flying cars by now, by the way? The Jetsons said we would. Different topic. But that moment where they come and said, oh, but we do think we understand what might be wrong with you. The mechanism of your cancer is not related to kidneys at all. It looks closer to pancreas. We're going to put you on a pancreatic cancer drug. And then you go on chemo for 3 months, not even a particularly bad round, and come in and say, you're cancer-free, you're eligible for a kidney transplant. I mean, it's like, holy cow, right? Now, what's going to happen next? They did not do this for me, is they'll sequence your immune system. They'll sequence your metabolism and how that works. And ultimately, we'll customize a drug specifically for you, right? So we're going to move to a world where there are base platform drugs, and then other drugs get customized on top of that. I don't know what this is going to mean for geriatric care. I don't know what this is going to mean for primary care. I can tell you I have lived through the promise that interferon was going to save our lives, and it did not. It made me very ill. And I lived through the era of interleukin, where that was going to be the next thing that was going to save my life, also made me very ill. But it feels like we're on a fundamentally different path because we're actually trying to understand the molecular mechanisms that are going on in your particular body and address that in sort of, that's the ultimate in sort of care customization. All right, So that's the framework that we've been using. I want to sort of end with just a couple of examples from some very old experiments, because what's old is new again. And I'm going to show you hopefully a video that you'll be able to hear, because it's one of the oldest things that we actually worked on, and I still think it's one of the most magical. In my own case, I talked about my grandmother. We also had falls in our family, so we're trying to deal with falls. This was somebody from our field work, a gentleman named Stan, who was a young person with advanced Alzheimer's and died rather quickly. His wife was a reporter, but she had had to quit her job to be able to care for him full time. And I remember her telling us, she's like, Eric, I am not a bad person, but she's like, I'm exhausted. And there's occasionally, I have to sleep for an hour, or I have to go get groceries because there's no one else to do it. And she's like, and I live in terror of that because I don't know if he's going to get up from the chair he sits in most of the day and go wander out into the street. But it's like, I can't afford to have anybody else come and deal with him, right? And I just remember that moment so poignantly. And I went back to the lab and I was like, hey, can we just put some sensors in his chair? There were she had a cell phone at that point. Can we, I think there was text messaging. I was like, can we at least just alert her, if she's asleep or if she's out in the world that this happened, right? So there's my second experiment. You saw the one with my grandmother failed. This one actually kind of worked. It was crude technology, but she loved it. She's like, it's better than nothing. Is the technology 100% accurate? No. She's like, but look at the baseline. I have no idea. I'm just going on whims of whether he's up and out of his chair or not while I'm off at the grocery store. And the next thing that we actually did was made it so that she could take control of a little dashboard on her computer and give that control to a neighbor for an hour while she was going out grocery shopping, right? So they could just look in virtually or in physically to see if he had actually gotten up, right? The seeds of that are very powerful and very magical, and it was technically difficult to do. So later on, we built this crude activities of daily living sort of tracking system. This was about 11 or 12 years ago. I'm going to just show you that demo real quick to sort of end this up. Let's see. It's so funny to pull these things back out and think, gosh, I thought they were going to be ready a decade ago, and they're still not widely available. So what we did in those times is we put a bracelet that was ugly. It was research. It was not a product. It wasn't the cool watches that we have now. But it actually let you track objects that you could tag around in the environment. And these were for families that were dealing with dementia and other kinds of things. So they would get this map of their home, and they could see, did mom interact with the kettle? All we knew, someone, we didn't know it was necessarily mom. We eventually put RFID tags on it, so we knew that it was mom, interacted with the kettle or not, right? And we started giving them reports about trying to sort of ascertain, was she able to sort of make tea by herself? Now, we did some really hard problems of trying to say, if she was having trouble making tea, and could the system detect it and then offer her a little video that the family shot on how to make tea in your own home? And that actually worked for some of the families, but it freaked other people out, because like, you got dementia, the TV turns on and shows you in your own home making tea. So, not a good thing. But it worked for some people, right? But what was interesting over time, we actually showed this to the VA in Seattle, who had a home care effort, and also in a nursing home that they actually had. And we were doing ethnographic studies of them and watching the staff spend enormous amounts of time filling out the reports that they had to do for the state and federal government, both quality indicating and tracking as well as for reimbursement. And it would be questions like, how many activities of daily living did they actually do on their own that day versus how many did you do? These nurses, well-intentioned, good people, were making stuff up at the end of their shift. And as we did time and motion studies of them, it became very clear that they were underreporting the amount of care. Thus, they were getting under-reimbursed for actually what they were doing. But it was also just interfering. The act of doing the quality reporting and the work was interfering with the spare little bit of quality time that they had in the person's home or in their apartment in the assisted living facility. So we put these systems in place, and it was initially for the family. So we created for the family this sort of trending photo frame that they could look at that would just show, based on our crude sensors and systems, were they getting exercise along the top? Were they able to sort of do meals for themselves? And were they able to sort of take their meds sort of roughly, right, crudely, with these little things that were sort of all in the environment. But very quickly, we actually said, wow, the same system actually could start to do the paperwork for the staff. And our system would sort of guess, a bunch of the answers that they needed to fill out. Was it 100% right? No. Was it better again than the baseline? Yes. And did it empower the staff at the end of their shift to be able to say, oh yeah, no, I did do all that care this morning, and I remember that now. It was just Mr. Jones had a heart attack in room 4, and I just forgot all the care that I actually did that morning, right? And this is one of the other sort of lessons about this. It's like we will wait and say the technology has to be perfect before we can actually do this. But the baseline and the bar is so low that it's like, hey, don't let the better be the enemy of the good enough to get started. The better will iterate over time and it will improve, but the good enough may have some powerful, powerful interventions in quality, both for the providers of care professionally as well as for what's going on there. So again, early work on the quote-unquote Internet of Things. And I say that to just share this last example, because it really starts to pull all the pieces of sort of personal health together. Assuming the video plays, I may just have to tell you the story. I worked with a man named Claude Goodman, who had a not-for-profit and was basically trying to use early technologies more than a decade ago to connect people who with working-age disabilities with frail seniors in the community to sort of solve a problem that we all sort of see. There's not enough resources to help these frail seniors and check in on them. And Laura, who's one of those working-age people with disability who was told by the state worker, just take your check and stop trying to get a job, right? Just take your money. If you make too much money, right, she gets, can't keep getting money from the state, so that sort of classical dilemma. So you're this young person who's just had a stroke or a motorcycle accident, and hey, spend your 30 to 60 years just sort of taking your check and do nothing, right? I mean, it's a huge problem. It's just real. It's real everywhere that we go. So what Claude tried to do, well, I'll try to sort of let him tell you the story himself, if we can get this sound to work. You'll see a younger me. Intel is committed to supporting long-term research and development of innovative uses of computing and communications technologies. One of the best ways we do this is actually fund hundreds of university grants each year that are exploring new applications, new interfaces, new usage models for these technologies that we often can't even think about today. The magic of Care Wheels is taking these two disenfranchised communities, people who are of working age with physical disabilities, and using technology to help them support frail elders who are trying to live at home in the community.
I founded Care Wheels because I wanted to see how we could use technologies that are available today to improve the quality of life of people living with disabilities.
With Care Wheels, I've been able to practice the abilities that I still do have.
The Care Wheels concept is to develop these new technologies by proxy, working with younger folks with physical disabilities and cognitive disabilities in order to develop technologies for frail elders. Smart home sensor technologies are here today. We've installed them around Laura's apartment in order to gather information that helps Laura live independently. All of the technology in Laura's apartment is designed to provide feedback to the researchers so that we can develop context-aware assistive technologies to allow her the maximum control of her environment
Kitchen light is on.
and allow her to be able to work from her own home as a telecare service provider.
Hello?
Hello. May I please speak to Marjorie?
We established a partnership with Adams & Gray in order to extend the Care Wheels test bed into the greater elder community.
We provide care to individuals who desire to live independently in their own home. But there's also a need for some support and reminding.
Oh yeah, I took it about 8:30.
For the Adams & Gray elder clients, it's very important for them to have confidence that they can go about their lives and know that somebody's going to check up with them on a daily basis just to see how they're doing, social conversation, and to provide them with things like medication reminders if they decide they need them.
We really didn't have a person on our staff who was able to make phone calls like that 24/7. And so as we partnered with Care Wheels, it worked out very well.
When it's time for Laura to check up on one of Adams & Gray clients, her telecare prompter pops up on her computer.
Telecare call reminder.
This provides her with a series of prompts that allows her to call her client, check up on them, and then, and this is very important, provide verification that she has accomplished the job. That verification is in the form of an email back to Adams & Gray.
You see this interesting bond forming between the two people, which I think is very meaningful to both parties.
They depend on me to do my job so that they're able to stay at home.
Laura benefits from her Care Wheels experience by having access to context-aware assistive technologies, the opportunity to work from home, a reason to get up in the morning to support folks like Marjorie who wish to live independently in their homes too.
All right, I'll sum it up there. So, that was a technical challenge to actually do that back then. Now I would argue it's a care model and business challenge. And what Claude was getting at there, you start to see the seeds of. He was trying to work on the business model and trying to think of a way that said, the home care agency can't afford to do this with a nurse, but if I can use technology to start to do this, there's a way in which it could help the person here, it could help the person there, the dollar flows would go like this. He started to try to innovate the whole experiment. And what I would say to you is, if we think about, I'll move to the ending slide here because I've blathered on for too long as always. If we think about the grand challenges and what this forum could actually really do, it's to do the true experiments, not sort of focusing on technology, right? But focus on a bunch of principles that we're trying to make happen for the future of care first and foremost. Place shift care to the least restrictive setting. Skill shift to patients, caregivers. Stop fighting the sort of licensure and protectionism turf and move actively. I mean, this is what China, this is what Europe is doing, right? They're saying, we're going to have to rethink licensure. We're going to have to rethink training. We're going to have to rethink kinds of care workers to skill shift. Time shift the care from reactive. Pay shift to team-based care and outcomes with a holistic approach to care. And technology shift from specialized equipment to everyday life technologies that are going to increasingly have these capabilities. But do it with a framework that doesn't start with the technology. I work for a technology company, and almost everybody I work with in government, in the private sector, in the not-for-profits are like, ooh, what can we do with your technology? I'm like, who cares? Stop thinking about it, right? The technology is like embedded within a sort of workflow that has to be done with clinicians, which is embedded in a sort of networked model of care, which is embedded within a financial system, which is embedded within government policy and framework, which is fundamentally a social covenant that we as a culture have decided this is how we're going to set ourselves up as people who need care and people who provide it. If we're going to innovate our way out of this demographic dilemma, then start with the social covenant and the care models first. Do what China did. Pretend that the tsunami has come through. Or no, you're going to start with a greenfield piece of paper. We know that we can't transition to that right away, but if you don't allow yourself to fundamentally think through the care model and what would the workflow be, what would the workforce be, how would we optimize our resources for that and the results that we want first, and then say, okay, what could be a sustainable business and payment model for that, right? That's based on a holistic definition of quality, that has connected care teams, that's fundamentally in preventive primary care, all of the elements of what we're starting to do, and then ask yourself, what's the technology infrastructure that you would actually need to be able to support that? If we can't get ourselves into that way of thinking, knowing full well that we're not going to have a green field or we're not going to start from scratch, but at least say, this is what it looks like, and then start to work on the business process transformation, the cultural process transformation, and the investment in technology grids in towns and cities transformation, we're never going to get there. And today I feel like home care is relegated to the niche. And more people are interested in it, but it's like, look at it as it's an additional capability that we need to add to the mainframe model. The thinking needs to be, how is home and community-based care the default? And going to the hospital, going to the mainframe is a rare exception. And what's the workforce and the business model to enable that? Thanks very much.